Hi, this is James Tcheng. I'm going to be spending the next 20 minutes or so with you chatting about femoral vascular access, complications, and management. So you might be asking, why do we need to hear a talk about how to establish access into blood vessels? After all, we all kind of know how to do this. In medical school, we're taught how to perform venipuncture and to start IVs, and in fact, femoral vascular access is really not that much different than using an IV setup with a large bore catheter to establish access to larger vessels. But I'd like to suggest to you that even though this is a technique that's been around since 1953, invented by Dr. Seldinger, that there actually is a bit of information that would help you become much better in terms of this particular procedure, particularly with the femoral vascular access approach. So just in case you don't know how to do this, at least the technique of establishing vascular access, let me walk you through the steps. The first one is obviously to prep and drape the area in which you want to establish vascular access. The second is to identify your landmarks and then to administer anesthesia. After all, you're going to be, as they say down here in the South, mashing on the groin, and so you want to make sure that the patient isn't too uncomfortable as you do this procedure. You need to advance the needle down to the level of the vessel at an angle of approximately 30 degrees. So if this is the vessel, this is the angle that you want to take. And the reason for that angle has to do actually with the angle of attack that you're trying to establish, so that the bevel of your needle is aiming right into the axial dimension of the vessel. Next step is to puncture into the vessel. We'll talk a little bit more about that in a moment. Once the needle is in the vessel, then you advance the guide wire through the lumen of that needle into the vessel. Keeping the wire in place, the next step is to pull the needle out. And then with the wire again in place, you advance a sheath over the wire and then you remove the wire. Voila, you have vascular access. However, even with now over 50 years of experience of establishing femoral arterial access, turns out that there's a fairly high rate of complications. Local complications of femoral, especially arterial vascular access, range in the 2 to 10% range, with the most common being hematoma formation and the most lethal being retroperitoneal hemorrhage. And so the question is, how can we improve on that basic technique to better understand what we really should be doing in terms of accessing blood vessels in the femoral triangle? So the rest of the talk is really about how to avoid complications. I'm going to assume that you know how to do the procedure. We'll go back through it again just to make sure. But the reality is the goal here is not just to get a catheter into a blood vessel, but it's to puncture the common femoral artery, or if you're doing venous access, the common femoral vein at the best possible location. Parenthetically, most of my talk is about establishing access to the common femoral artery. I will mention in just a few slides about where I think it's the best place to get into the common femoral vein, but most of my comments really are about the common femoral artery access. So what do you need to do in order to avoid complications with respect to your femoral access? The first one is to know what landmarks you should be using so that you can understand where that you need to puncture into the skin, so that once you've accounted for geometry, you can actually access the femoral artery at the right spot, at the best possible location. And I'm going to show you in a few moments where that spot is. If you have the opportunity, if you have the benefit of being in a catheterization laboratory, fluoroscopy turns out to be your best friend to trying to figure out exactly where that spot is. I have a bullet point there about feeling the force. If you're doing this right, as you introduce the needle, you should actually be able to feel the artery pushing back against you so that you know exactly where you are as you're trying to puncture into the vessel. Even the vein has some resistance as you're trying to access it with the needle. Single front wall punctures only really are the standard. So I get rather upset in the cath lab when I see my fellows doing this, using patients as pincushions. That's not the right way to go about trying to establish vascular access. And in fact, I would argue pulling negative and then doing it that way, again, is not any better because you're potentially lacerating different structures that are there in the femoral triangle. So remember that the objective is to use a technique which allows you to do a single front wall puncture only. All right, so what is the sweet spot? I want you to take a look at this image. This is a 3D reconstruction using computed tomography and then reconstruction algorithms to identify the aorta, which you can see up at the top. Let's see if I can get my pointer to work here. Up at the aorta, bifurcating into the iliacs, and then as it crosses around the level of the inguinal ligament, it becomes the common femoral, and then bifurcates into the profunda femoris and the superficial femoral. And because I hit the arrow, it actually shows you the key spot that is the magic or the sweet spot for obtaining femoral arterial access. There are several reasons why that's the right spot, and I'm going to go through them, but the first thing that is a concept really to start off with is that when you're accessing the femoral artery at that spot where the green arrow is, when you remove the sheath, you can actually then put pressure on the artery against a hard surface. If you look in the upper right-hand corner, basically it's the concept of pushing against an anvil. The other places, the place where you don't want to stick, if you will, is low. When you're sticking low, there's really nothing that you're pushing up against subcutaneous tissue. And when you're sticking high, up in this red area, the odds of retroperitoneal hemorrhage and hematoma actually increase upwards of 18 to 1 over other locations. As you can see up in the abdominal cavity, you're really not pushing against anything. And so I think it goes without saying why this, at least for the first point, would be a great place to establish femoral vascular access. So using that as the starting point, that's what we're trying to hit, the question is, what landmarks do you have that you can use to identify that spot inside the patient's body? Well, there are really 4 landmarks that people talk about. First, there's the inguinal crease. Second, there's the point of maximal pulsation. Third, there are your bony landmarks, including the inguinal ligament. And then fourth, there's the ever popular prior puncture site that you see here. Now, let me try to explain to you both what are used in terms of the landmarks and then what you should be looking for, what you should actually be using as your landmark. This is a study done in 1990 or published in 1990, just asking a series of radiologists, what landmark do you use for your femoral puncture? And you can see the most popular one is the femoral crease. The second one is the point of maximal pulsation, and then the rest of the numbers that you can see there include bony landmarks, etc. And the question is, which one of these or combination of these is the right one? So is the inguinal crease the answer? Well, I showed you this model before, and I would suggest to you that that's probably not really representative of your patients. You look on the right-hand side, the question is, where is the inguinal crease? Another thing that happens with age and with corposity is that your inguinal crease tends to sag, and that it does not remain constant relative to that spot that I identified for you before, and that's right on top of the femoral head, where you're going to get the maximum amount of pressure on the femoral artery to get hemostasis. You might say, well, let's take a look at a classic textbook of medicine, like a Netter drawing, and say, what anatomic landmarks should we be following? Well, unfortunately, the textbooks even get it wrong. There's 3 misconceptions, despite more than 50 years worth of experience in terms of femoral vascular access. The first one, again, relates to this inguinal skin crease that I've mentioned already. It does not stay constant. Only in the very young does it really even identify the top of the femoral head. The second misconception is that the bifurcation of the common femoral into the superficial femoral and the profunda is always low, as you can see here, well below, at least in this artist drawing, well below the lower margin of the femoral head. And the third misconception has to do with the location of the inguinal ligament. Yes, you can feel it, but just as with the inguinal skin crease, the inguinal ligament also tends to sag over time. So unfortunately, none of these are really all that reliable in terms of landmarks for you to use for establishing femoral arterial access. Let me just show you an example of what happens if you use the inguinal crease to establish your femoral access. This is a radiograph which shows that where we have ended up sticking the sticking the femoral artery is very low. It's well below the midpoint of the femoral head, and in fact, in this particular case, it's in the profunda as shown on the right-hand side radiograph. Again, the comment here is this is a little bit different of a drawing, but as you can see by that hashed arrow line there, at least this particular artist is drawing that skin crease a little bit lower than what you saw before in that artist rendition. The next question is, where is the bifurcation of the profunda and the superficial, and why does that matter? Well, it turns out that the profunda needs to be considered to be the left main of the leg, and so I would suggest to you that you really want to try to avoid the profunda femoris if at all possible. This is a survey that was done of 200 consecutive patients asking the question, where does the bifurcation of the profunda and the superficial femoral occur relative to the common femoral artery? And you can see in the green, about 55% of the time, it's below the inferior border of the femoral head. About 22% of the time, it's at the inferior border. So if you add those two numbers up, it's about 3/4 of the time, it's at or below the level of the inferior margin of the femoral head. Unfortunately, there's a small proportion of time, about 1.5% of the time, where it's even above the midline of the femoral head. But most of the time, it's somewhere in the area where you have, where if you're sticking right at the top, the middle of the femoral head, you're going to be above the bifurcation of the profunda. This is a femoral angiogram to demonstrate a relatively high stick, but you can also see by hitting that midpoint at the femoral head that you basically have avoided the profunda in establishing vascular access. The other thing that you need to remember is that there is one other structure that defines the upper bounds of where you want to strike, and that's the inferior epigastric artery, the IEA. The IEA wraps around the inguinal ligament, so that actually is a pretty good landmark to tell you where the inguinal ligament is, and it suggests that you really don't want to be too high either, that blue arrow where the midpoint is probably the best place for the strike zone to occur. So when I say strike zone, what am I talking about? Let's take a look at the measurements of the common femoral artery. The common femoral artery is typically designated for when it emerges from the inguinal ligament, under the inguinal ligament, to where it bifurcates into the common femoral, from the common femoral into the superficial femoral and the profunda femoris, or the deep femoral artery. And as you look at this, this is somewhere in the neighborhood of around 45, maybe 50 millimeters long. This length, however, that is 45 to 50 millimeters long, or 4.5 to 5 centimeters, does not take into account the inferior epigastric artery. It does not consider the implications of a stick in the common femoral artery above the bifurcation but below the femoral head in terms of your ability to compress. Again, a no-fly zone, if you will. And it doesn't take into account the fact that you still have some patients who have a fairly high bifurcation. So the answer to the question is, where should I stick, or what's the best point to stick the femoral vessel? And it turns out that I think that this cumulative target zone is somewhere that's about 1 centimeter long, that is right below the center line of the femoral head. And as you saw in terms of the landmarks that I showed you before, this frequently correlates with the point of maximal pulsation. So the answer to the question, 1, 2, 3, or 4, inguinal crease, inguinal ligament, point of maximal pulsation, or previous puncture site, the real answer is you want to establish access through the skin so that the spot that you hit is at the point of maximal impulse. Now, how can you pretty much make sure that this happens every time? So here's on the right-hand side a radiograph, on the left-hand side an artist rendition of the strike zone. And what I would suggest to you is that the best way to do this is with what's called the double fluoroscopic technique. The first one is to take in the AP projection, that's with the camera at no angulation at all, no REO, no LEO, no cranial, no caudal. Take it straight AP and identify where that point is that you want to hit with your forceps. Then, as you're introducing the needle, the second time you turn the fluoroscopy on is when you are right at the top of the vessel. You can actually feel it pulsating back at you. You know you're right there, and just hit the fluoro again to make sure that that's the spot that you want to hit. And then once you're there, then just use a kind of a strike motion, advance the needle about 4 or 5 millimeters, and you should be right in the middle of the femoral artery. All right. Rest of the story then, again, you should know how to do this, but we've been focusing primarily on point A, that is establishing pulsatile blood flow upon entry. Once you see the blood dripping back, then the next step, item B, is to advance a J-tip guide wire. Most important thing about that is that as you're advancing the guide wire, you should feel very little resistance. If you're feeling resistance, especially if you're in the cath lab, but even if you're not in the cath lab, if you're just trying to establish vascular access in the unit, etc., make sure that that wire goes nice and easy. Once the wire has been advanced far enough so that you have sufficient wire to advance your catheter, you hold the wire steady and you remove the needle, leaving the guide wire inside the vessel. You then advance the sheath over the guide wire. You should use a little bit of a twisting motion as you're advancing the sheath over that guide wire until you get the point where the sheath is advanced so that the hub of the sheath is right at the level of the skin, and then you can remove the guide wire and the dilator. Another point about needle management is if you fail, if you think you're in and you start to try to advance the J-tip guide wire but it doesn't go, stop. Pull everything out, compress for at least 3, 4, 5 minutes, and then start again. And again, as I mentioned before, you want to avoid multiple sticks and you want to avoid posterior wall sticks. Let's then finish up then talking about complications. What are the predictors of complications? Well, I think I've made the point about the puncture location as being the one thing that you can likely control, where excellent technique really demands that you spend enough time so that every time you puncture the vessel, you are doing it in the right spot. But how do you know you're there? You won't know unless you take a femoral angiogram. So one of the criteria that I like to judge our fellows by is when they do the femoral vascular access on femoral angiography, have they hit the lesion at the right side? The other complication predictors are shown here. The other ones that you can figure out by femoral angiography is the size of your vessel. The smaller the vessel, the more likely you are to have complications. And then also if you have a lot of vascular disease at the puncture site. It really is important to obtain a femoral angiogram so that you can assess whether or not your patient is at risk for having a complication related to the femoral vascular access itself. I mentioned before about retroperitoneal hemorrhage. This is data from Steve Ellis, published in Catheterization and Cardiovascular Interventions in 2006, demonstrating that the odds ratio of retroperitoneal bleeding is increased to 17.6 times the baseline if your sheath is superior or really at or superior to the inferior epigastric artery. So please don't stick through the inguinal ligament. You should be able to feel it, so one of the things you want to avoid is sticking through it. You definitely don't want to stick above it, and so the right technique is to actually find the place that you want to enter, but also make sure that you're sticking below the inguinal ligament, that you're under the inguinal ligament so that you don't lacerate the inferior epigastric artery and that you don't end up with a high puncture that you can't compress. When you do develop a retroperitoneal hemorrhage, the most common first sign is actually hypotension. Not anemia, because it takes a while for the bloods to return, but actually the nurse will call you and say the patient's blood pressure is low, will you come to see the patient? Well, therefore, it's very important to understand what the patient's pressure was before you started the case, to understand if the new blood pressure is actually low or if it's a reflection of that patient's baseline state. If the nursing staff calls you about hypotension, treat it as an emergency. Drop everything that you're doing, go see the patient. If you can't go immediately because you're in the middle of a case, send somebody else. I would like to tell you that the other signs, abdominal tenderness, diaphoresis, etc., are also useful, but unfortunately they're not particularly specific. So you really do need to have your ears open for that call that suggests that the patient is hypotensive. There are some signs that you can look for. There's Cullen's sign, which is periumbilical hemorrhage and ecchymosis. There's Gray-Turner's sign, which is ecchymosis in your flanks. You probably don't want to wait for those, because most of the time that you find, or we find these, the patient is already in dire straits or worse. So please don't wait for these particular signs to appear, but instead act upon hypotension. The time to first clinical manifestation is important. Most of the time it occurs early, but notice that out even to the 5, 6, 7 hour range, patients can bleed or start bleeding to the point where they actually have hypotension, if you will, the first clinical manifestation. So don't think you're out of the woods just because you finished the day and you've gone home. It is not over till it's really over. How do you then work up retroperitoneal hemorrhage? Well, if the patient is hypotensive, obviously you want to start fluid replacement, but you don't want to send them to the CT scanner. So please, if a patient is hypotensive and you're in trouble, the patient's in trouble, involve the cath lab. Think about whether that patient should actually return back to the cath lab for a contralateral stick access, and then taking an angiogram to determine whether or not there's a leak, and then putting a balloon at that leak site. That's actually a much better way of managing retroperitoneal hemorrhage than it is sending the patient to the CT scanner just to try to document what's going on. The other complication is related to a low stick, and this is pseudoaneurysm. What is a pseudoaneurysm? These are two ultrasounds where you see FA is the femoral artery, N is a neck, and that's literally the needle tract, which doesn't close up, and then P stands for the pulsatile mass of blood that occurs, that collects. That's the pseudoaneurysm. The reason why this is relevant is that if you are unlucky, if your patient is unlucky, the pseudoaneurysm can dissect in tissue planes, and you can dump a lot of blood into the leg without the patient really complaining a whole lot, other than, again, presenting with hypotension or worse. So you do have to have a high index of suspicion for this. The most typical and classic physical exam findings are, one, tenderness that's out of proportion to what you would expect. Everybody's a little tender after having a femoral artery puncture, but tenderness out of proportion as to what you would expect, and you hear a bruit. And the bruit is from the turbulence. You can see that especially in A, where you see turbulence that's in that neck. And so the approach is to, most of the time, inject thrombin directly into the neck. You obviously don't want to be letting that thrombin go into the femoral artery itself, but you carefully inject under ultrasound guidance. Radiology will do this. You inject thrombin. You can also sometimes compress these, and for ones that can't be closed because the tract is very large, once in a while we do have to send our patients to surgery. What are some newer ways that have been introduced over the last 5 to 10 years that improve our access? The technique, one is ultrasound guided access. What ultrasound guided access does, it really makes sure you understand exactly where the femoral artery and the femoral vein are. One of the things that's remarkable about ultrasound guided access is that you don't have erroneous kind of a pincushion based approach to access, but instead you are able to hit the femoral artery with much more regularity. The other one is micropuncture. Micropuncture takes a much smaller needle. Basically, it has two advantages. One, it's more comfortable for the patient, even though the needle sizes don't look that much different. It actually is a lot lower profile, and because the lower profile induces a lot less trauma. With less trauma, it causes less irritation. And the second one is if you are unsuccessful in establishing vascular access, the hole that you've left is obviously a lot smaller, and getting good hemostasis before you move on to try again is an advantage of the micropuncture technique. Better technique really does result in a better result. This is a patient who had 2 femoral artery punctures. If you can look on the patient's right side, you can see that the first puncture was made approximately in the inguinal crease. The second puncture on the left side was made about 1.5 centimeters, maybe 2 centimeters higher. Better technique on the left-hand side, that is accessing the femoral vessel exactly on top of the femoral head, resulted in better hemostasis and a much happier patient and a better result. Before I close, let me add one parenthetical. I've talked almost exclusively about femoral arterial access. I do want to mention femoral venous access. The technique, the Seldinger technique, really isn't any different, but the location where you should access the femoral vein is a little different. Here, the inguinal crease is the place that seems to work the best, and it's because that's the least distance between the skin and the femoral vein. As everybody knows, the femoral vein is more medial than the femoral artery. As you're thinking about getting femoral venous access, still some of the same principles hold. You should make sure that you understand what your anatomy is. You try not to stick the artery, but the place I would actually recommend that you stick is in the femoral crease, mainly because then you have the least distance to go, and as you pull things out, the amount of pressure that you have to place is relatively modest. So let me close then with this this graphic, which I hope you will enjoy, that explains what it is that we're asking you to do in terms of vascular access. All right, so I hope you enjoyed that little demonstration of making sure you hit the mark. In some ways, that actually is what we're asking you to do, especially with femoral arterial access. It is to try to make sure that you have the most appropriate access into the femoral vessel, thinking not just about the things that you need to accomplish relative to the arterial procedure itself, but also how to reduce the complications that could occur after you've removed the vascular access sheath. Thank you very much for your attention.